Good morning, everyone, and thank you for joining us. Today is the first Telehealth Immersion program event this year, and we are excited to have Dr. Matthew Sakamoto and Sarah Krug join us today to expand on their recent publication featured in Telehealth and Medicine Today, Enhancing Digital Empathy and Reimagining the Telehealth Experience. Dr. Matthew Sakamoto is a primary care physician at Terra Practice, a virtual first primary care practice in the Sutter Health Network in San Francisco. He is also fellowship trained in clinical informatics with a focus on virtual care. He also has worked as a virtualist for telehealth startups, including Teladoc and PlushCare. Sarah Krug is the CEO of the Healthcare Collaboratory, a global innovation hub that's focused on cultivating trust in healthcare and advancing health equity by amplifying the voice of patients, care partners, and healthcare professionals in the design, development, and continuous improvement of healthcare innovations. Sarah is also the executive director of Cancer 101, a patient advocacy organization, and is the author of A Roadmap to Wellness with another book to launch this year. She's also a global speaker and recently gave a TEDx talk called The Patient, Dr. Tango. And without further ado, Matt and Sarah, I'll turn the floor over to you.
So from our end, like I said, I'm Dr. Matt Sakamoto, really excited to co-present with Sarah Krug, and we will get started. Just some quick disclosures here. So I've sit on a couple of journals, as well as have worked for a couple of the other telehealth companies. So all of these are, kind of our own personal opinions, don't represent any of those of our employers. So really thinking about telehealth 1.0. So kind of telehealth started, prior to the pandemic, but really kicked off then kind of just looking at the adoption curves of telehealth. So the front end was really, how do we make this work? So COVID-related rapid implementation, a lot of growing pains, just kind of figuring it out. But throughout this, I think we've kind of learned like the basics of best practices. So from the clinician side, thinking about how do you have good eye contact, good lighting, making sure your internet connection is good enough to have a clear connection with the patient. And on the patient side, really thinking about those basics. So finding like a quiet, private space to do visits. So when Sarah and I were talking, we kind of realized 1.0 has been covered and really want to be able to do the deeper dives today. How do you take just really having a connection by video and actually creating that humanized connection. So what we're going to talk about today, kind of a story in 3 parts. So first one is really developing digital empathy. So talking through what that is, how does that differ from empathy in and of itself, and how does that translate digitally? Advancing the virtual physical exam. So there are parts that you observe visually, but I think there's also, we'll talk through ways that you can heighten the physical exam, what you can do by video, and not have to have patients come into the office. And finally, talking to telehealth literacy. What can we do to really bolster both patient side and clinician side of understanding telehealth and doing that better? Looking ahead here, I'm going to circle back a little bit. And then just looking at the empathy map here. So kind of the say and do are things that you're able to observe on the outside. So the digital empathy part is what we say. Performing the virtual physical exam is what we do, and really using those as the window to how to get to how the patient is thinking and feeling. And as Bernadette mentioned, so we put together a lot of these ideas in a publication in Telehealth and Medicine Today. So this is really just an overview and a first look at some of the topics that we did. If you want a deeper dive, definitely we recommend checking out the article. And I'm going to hand it off to Sarah now for really her patient advocacy and patient perspective.
Thank you, Dr. Sakamoto. It's a pleasure to be here with all of you today. So at the Health Collaboratory, we've been entrenched in a series of co-design sessions with patients and their care partners across health conditions to really understand any barriers they've encountered with telehealth. And our intent is to put a spotlight on the challenges so that we can map out potential solutions and essentially reimagine the future of telehealth through the patient lens. And specifically with telemedicine, the goal was to envision what the ideal visit looks like before, during, and after that virtual visit. And we started to create guidance and education that patients and care partners can use to help them better prepare. And so today I won't go through all the challenges that patients highlighted, but thought it might be interesting to see a few quotes from patients. And again, I won't read them all, but just to share a couple. One patient said, "I'm so focused on making sure that the technology is working right that I forget some of what we discussed. In person, I was taking notes, but I haven't been able to multitask." So obviously here it's clear that this is a new way for patients to communicate with their clinicians. and they haven't mastered that the balance between interacting virtually and taking notes. Another patient shared, I don't feel like I can share private information with my family listening in the background, highlighting that privacy is often an issue whether a patient lives in a multi-generation household or they don't have dedicated space where they can privately conduct that visit with others at home or even at work listening in. And we obviously want them to be able to share sensitive information during their touch point with the clinician. And if we can go to the next slide, please. And by the way, this is not intended to be a didactic presentation. We'd love to hear your perspectives, your questions, and even your challenges throughout as we share what we've learned. So in our work with patients and their care partners at the Health Collaboratory, we conduct a series of what we call first impression studies on the various elements of healthcare to understand the psychology of first impressions on a patient's behaviors, their decision-making. And we often underestimate how a first impression can impact a patient's sentiments, their perceptions, their information-seeking patterns, and their behaviors, and ultimately how that can influence their cascade of decisions. And so we conducted a first impression study with a focus on telemedicine. And the data you see here is from September of 2020. And in a nutshell, we had 578 patients across conditions that participated. 62% indicated that their subpar or their unsatisfactory experience using telemedicine would influence their decision to engage in another telemedicine visit. 76% indicated that they had at least one challenge during that first telemedicine visit. And then a whopping 84% indicated that they didn't feel like any preparation went into that telemedicine visit. And that's both on the patient and the clinician side. And then as you saw on the previous slide, one patient felt like the doctor was meeting them for the first time, even though they had several in-person visits prior to that telemedicine visit. So again, in our work with patients, we've also incorporated patient ratings of the telemedicine visit to understand deficiencies and opportunities where they can rate various dimensions of the visit, as well as their overall experience. So in summary, first impressions matter. We collectively have an opportunity to introduce telemedicine as a convenient option that patients can engage in alongside traditional in-person visits. And we've learned a lot since September of 2020. But again, these are simple steps that we can take to ensure that we improve those first impressions. And so an important way of improving that first impression and connecting with patients virtually is through the emerging science of digital empathy. And if we can go to the next slide, I'll do a deeper dive into empathy and then segue into how empathy can be further conveyed in a digital world. So I'll just start here with a basic overview of empathy, which is it's a multifaceted concept, right? That's defined in the literature various ways. But essentially, empathy is our ability to see the world through another person's eyes, to see what they see, to feel what they feel, and to experience things the way they do by putting aside our preconceived beliefs, our thoughts, to understand their emotions, their thoughts, their environment, their challenges, their realities. Ultimately, empathy is that emotional bridge that helps us form a connection and understand the way that people see, understand and interact with the world around them, and how that can impact their health. But the point I want to make is it doesn't stop there, because empathy without action is not empathy, right? It's important we communicate that understanding to a patient and then act upon that understanding in a way that's helpful to that person. And if we go to the next slide. So here I'll touch upon the three aspects of the contemporary aspect of, or the contemporary concept of empathy that are often explored in the field, recognizing, again, there's often debate on which components should apply to healthcare. And this has evolved over the years with a shift in focus to a person-centered approach. And there's research that shows how empathy can not only improve patient satisfaction and their experience, but also have an impact on a patient's health outcomes. So 3 domains: cognitive empathy. That's where we really take the perspective of another person, also known as perspective taking. And we put ourselves in their shoes to objectively gain a better understanding of their situation and their experience. In a sense, it's seeing the world through their eyes to gain a better perspective. And then we have effective empathy. And that's often described as the emotional engagement and our ability to understand and accept another person's emotions unconditionally, without preconceptions, stereotypes. It's often linked to the desire to heal versus a sense of duty to eradicate that disease. And it's essentially feeling what another person's feeling, or as they say, catching their feelings. And then lastly, behavioral empathy is taking action to help others based on that understanding of their situation and their feelings. That's where we leverage both emotional and cognitive empathy to inform the actions that we take. If we can go to the next slide. So with the digitalization of healthcare, we're no longer constrained beyond the constraints of time and geography. There's boundless opportunity to connect meaningfully, to communicate, to share data. And although the underlying principles of traditional and digital empathy constructs might be the same, it's important that we recognize that the practice of empathy may need to evolve through the emerging science of digital empathy. And again, I'll touch upon a few techniques, but essentially, digital empathy is the set of cognitive, emotional, social skills required to understand, to analyze, to evaluate, to reflect, to feel, and to engage through digital technology. If you go to the next slide, please. So as we think through humanizing that virtual visit, there are a few things that can be done to establish a meaningful connection. With these virtual interactions, we have to compensate for the cornerstones of the traditional medical encounter, such as human touch. And I'll get into some of the details on the next slide. So going back to the points that I made earlier about first impressions, there's research that shows that first impressions, generally speaking, are greatly influenced by nonverbal communication and body language. So people who are more expressive with their facial expressions, their body language, displaying a positive emotion tend to be more likable, for example. And not that this is about likability per se, but this goes hand in hand with website manner and improving the experience. Social cues can be harder to pick up on during a virtual visit, whether it's a clinician reading a patient's facial expression, or even the patient interpreting a clinician's nonverbal cue. And in order to make eye contact with the webcam, which can be somewhat awkward, while we're also picking up on important reactions or facial expressions a patient makes, it's important to practice situational awareness, right? It's a bit of a balancing act. So your tone, your cadence, your inflection, the natural rise and fall in your voice can not only help place emphasis on certain points you're making and improve enunciation, but it also demonstrates to the patient that you're listening and that you're engaged in what they have to say. And then there's also power in pause, which not only gives space to a patient to reflect on an important point you made, but it can also prompt them to ask a question or even engage in conversation and fill in details with their story. And a pause can be a very powerful communication tool to demonstrate that you're listening to that patient. And if we can go to the next slide. So frame, even though frame might seem trivial when it comes to that virtual visit, it's important to recognize that this webcam is the window to that virtual visit, right? And in order for you to communicate with those nonverbal cues and that body language that we discussed earlier, it's best to widen the frame of view so that the patient can see your hand gestures. They can pick up on the positive vibe that you're conveying through your posture and your open stance. It can also help avoid that talking head effect with a closely placed webcam. Go to the next slide, please. So an important extension of digital empathy is active listening, which is when you take the time to absorb and really react to what that patient's saying unconditionally. And again, without judgment, without bias. And active listening, it is a key tenet of narrative-based medicine, which is defined as the commitment to understand the life and the unique narrative of the person with a condition and their family, not just their disease, right? So a person's story, it's one of the most overlooked diagnostic tools in medicine that can not only shed light on their history, but also provide context around their experience and their challenges in managing their disease. And I often say that the patient's life expertise expressed through their story, combined with the clinician's medical expertise, that's the essence of participatory medicine, or what I refer to as the patient-doctor tango. But we often don't give enough prompts for the patient, for the person with a disease to share that story. And we have to recognize that, not all patients are natural storytellers. So prompts and expressing curiosity, they're all important in making a patient feel safe and sharing their life with a clinician. Patients want to feel heard, and their ultimate goal, or our ultimate goal, is to use narrative-based medicine as a way to shift mindset from how do I treat this disease to how do I help this person. And if we can go to the next slide. So for those who are listening in, feel free to share both your recommendations, your challenges in implementing digital empathy, what's worked, what hasn't. But in the meantime, I'm going to ask Dr. Sakamoto a question. Recognizing that digital empathy is easier said than done, As we move from theory to action, how do you establish a connection with new patients?
Yeah, no, great question. I think since I've been doing the virtual health thing for a bit, but even prior to doing a lot of the telehealth work, I'd worked in urgent care a bunch. So I think having to make that connection with the patient for the first time was kind of part and parcel of my day. And a lot of it is not what brings you here, it's kind of just asking about the patient. And I think that helps a lot. So in my new patient intakes, it's kind of, we actually have on our form, like I forget how the wording is, but it's basically tell us a fun fact about yourself, right? So it's something that is potentially a point of just connection. And particularly when I started doing a lot of work during the pandemic across state lines, because of a lot of the emergency licensures, just talking about, where are you in Alabama? I've never been there before. Or, oh, you're in Hawaii. I grew up there. So there's these places about like, where are you just even physically located right now, that can serve as a personal touch point. And for me, that's a great way to break the ice.
Absolutely. And then how is that different from maintaining a connection with a returning patient that makes them feel like you know who they are?
Yeah, and I'll share a trick. I think I learned this when I was in medical school, and I'm sure a lot of docs use this. Is actually documenting in the note not just what the medical thing was, but like if they're about to go on a trip. Like I will actually write that down. It's like going to Tahoe like this week, and when they come back, like I'll actually look and reference that back. So there's just these little pieces that kind of show that you're listening. And I'll be honest, my memory is not that good, but taking the time to jot that down at the end of their their visit in December, and when they come back to check in with me in February, again, both for in-person and virtual, helps to maintain that connection. Again, it's mostly just what is the personal side of stuff. The things that go under social history aren't just smoking and alcohol use. I think that's also just what's going on with them personally.
Absolutely. That's a fantastic tip. So we've talked about the power of first impressions, the practice of digital empathy. We've talked about the impact of actively listening to a person's story through narrative-based medicine. And now Dr. Sakamoto will give us a primer on the virtual physical exam, giving us a glimpse into some of the mechanics behind a telemedicine visit. Dr. Sakamoto, over to you.
Yeah, no, thanks so much. So yeah, I said, like right now, so we talked a lot about the say and how do you make that connection. And even that, there's actually a lot of action-oriented things that go into developing digital empathy. I'll focus more on like the actual action. So kind of the do portion of this talk. So, and I can respond a little bit to one of the questions that I saw come through in the chat is, what is the quote unquote standard of care as you're doing a virtual physical exam compared to the in-person physical exam? One thing that I do want to talk through, and we'll talk to this a little bit at the end as well, is not to equate or recreate the virtual exam as part of what we do in person, but really kind of use the virtual as an extension and not be equivalent. And I'll talk through kind of what I mean with some of those things as well. So the virtual physical exam, I kind of say, look, but don't touch. One thing that you can do, most things are what you observe, what are observable things. So kind of looking at, how do they generally look? Watching their breathing patterns, you can observe musculoskeletal things, neuro, and of course, psychiatric portions of the exam. The highlighted part, though, is the environmental scan is something that I've added. One thing that I realized that over the course of the pandemic and just doing a lot more video visits is that telehealth really brought back the home visit. So not just, again, looking at the patient, and this goes back to Sarah's point about frame, is actually trying to zoom out a little bit and see like, what does the home look like in the background and or sound like? Because I think there's a lot of the sounds of pets in the background, kids running in the background, things like that, or older family members. So really getting a sense of what is the environment that your patient is in, for me, has yielded lots of insights, I think, different than in a little more sterilized setting when they come into the clinic. So really bringing back that idea of the environmental scan. One other thing that I'll share, and I've discussed this with different colleagues, is kind of what does that environmental scan look like on my side? So do you use a opaque background, a blurred background, show the whole background? I've kind of gone back and forth and have really settled, as you can see even behind me, I've settled on showing kind of the whole background. There's a level of humanizing and connection there. Like I said, there's like a little surfboard, there's some pictures. So in the same way that in an office, you can kind of add your own flair and the patient is inviting you in their home, I think, so particularly when I work from home, being able to share a similar thing with my patients is something that I lean on and move towards. And just thinking through what are some of like, again, I call it advanced virtual physical exam techniques. There's a lot of great resources out there, and I'll have a slide that kind of shows them. This one is from Stanford, and I call it PPE. It's the physician-directed patient self-exam. There's a lot of things that that we used to do ourselves: feel the belly, listen to the heart. Can't necessarily do that across a screen, but there are a lot of things, again, thinking about frame, having the patient step back, taking a broader view, that you can really use to elicit some of these things. And a lot of it is trust. So that's why we spent a while talking about digital empathy, because being able to trust the patient's report on what they're doing as you guide them through it really helps inform me when I'm examining them virtually. So like the upper respiratory exam, if you had asked me 2 years ago, could you do anything respiratory over video? I'd say absolutely not. You have to listen to lungs. Clearly that's changed. And kind of saying, asking them about symptoms, but also like patients can self-examine their lymph nodes. So you walk them through where should they be feeling? Is it rubbery? Is it painful when you push on it? So again, walking the patient through it and then trusting their report on what they feel like, on what they feel while they're performing the self-exam is really important. Thinking through the next one's on the right side of the screen, the lower back exam. Again, this is where frame is super important, because patients can self-report different parts on their back, but having them actually stand up and say, like, point with one finger, where is it hurting the most? Is it midline? Is it just off center? And being able to visualize that, again, virtually, but not being afraid to have the patient kind of get up and move around. And then again, walking them through the different dermatome levels. So it's really being direct and clear as to, where are they pointing? Do you feel sharp, light, etc. And again, trusting the patient report on the portions of that. And then just for space, I didn't show the shoulder exam, but in the same idea, you'd want them to step back, and then you can walk them through the different rotator cuff motions, either themselves or sometimes a spouse or partner can assist with the patient self-exam. As I mentioned, so the respiratory thing, clearly with COVID, I think the scope of what, at least for me, what I feel comfortable examining virtually has definitely increased. This is from BMJ, and specifically kind of thinking through what parts of the virtual exam are you able to do just by visual or with household things. So really, even over the phone, as you can see, you can just ask, you can assess, what is their state of breathing, and then ask them, are your face or lip color different? Same thing over video, you can visually observe color of the skin. The other parts, patients can take their own self measurements, and really functional testing is what I've leaned on a little bit more. So again, you can't listen to the lungs, but having them actually get up, walk a lap around their apartment and come and sit back down. Are you feeling more or less, shorter breath, and observing them, do they look visibly shorter breath by having them do that? So again, not being afraid to have the patient kind of get up and move around a little bit is a way to get a lot more information than just talking to them over video. Another great article, this is the Cardiac Telehealth 10 out of Northwestern. So really, it was published in cardiology, but a lot of these things carry over into my internal medicine primary care practice as well. Vital signs, most of these things can be done at home. We're pretty easily done at home. Home blood pressure cuffs are pretty readily available at a local pharmacy. Most people have a scale at home. Really doing the skin assessment, looking at the HENT part. So the ones I highlighted in red are things that are accessible by visual exam. Watching for wheezing, looking at the abdomen, and then particularly the wearables part, I'll highlight and talk about a little more in the next section as well. And one thing I also want to highlight from this paper in particular is step 10, social determinants of health. In the same way I kind of described, like you get to observe the patient in their home environment. What are the other things kind of that are clearly not directly medicine related, but really have a strong impact on the patient's health? So thinking about what are the extensions of what we can do, again, just by visualizing and kind of walking the patient through things, is a lot of these remote patient monitoring devices and just peripheral devices in general. Again, another reference down here, Ali Ansari had a really good article about what are the parts of the physical exam that can be done with, highly easily done across just video, and or like kind of tough to listen to across virtual boundaries. But as you can see, there's different things. You can have a home EKG, the live core thing. Echo is EKO is a Bluetooth stethoscope that you can use to listen remotely. And I've actually a couple of places deployed that for remote emergency room, particularly when they're doing social distancing. Apple Watches are becoming more and more ubiquitous, and even have a pulse ox incorporated into these. So these are all things that patients either have at home, or you can work with your health systems to think about deploying for particular populations. And this is a good example. I'm on Twitter, probably too much, but there's a health tech influencer that you have these groups like Oscar and other insurance companies that are actually sending these devices so that when the patient needs to have any kind of visit, they have a thermometer, blood pressure cuff at the ready at home. And lastly, so these are kind of a recap of the resources that I covered here. And really, a couple of them, I just have colleagues that work at both Jefferson Health, Cornell, Stanford, really good telemedicine courses as well that they offer for CME. And really thinking through this again, kind of, so from my side, these are the things that I walk the patients through. But Sarah, from your end, kind of as a patient or with patients that you've observed, what are some of the major challenges in kind of patients performing exams on themselves for the first time?
Yeah, so it's interesting, and this is for the audience. When Dr. Sakamoto and I were planning this webinar, I thought he was going to suggest that he do the virtual exam on me live. I'm glad that he didn't suggest that, but maybe next time. But my big confession for the day is that I've actually never personally participated in a telemedicine visit for my own healthcare. But I have participated in about 20 telemedicine visits with other patients that I've helped navigate. And it's been quite eye-opening since every doctor has their own technique, right? And separately, I've participated in co-design sessions with patients around their telehealth experience. And many patients feel like something will be missed if they don't see a doctor in person. There's that reassurance that a doctor can convey through human touch. And that's in alignment with Dr. Abraham Varghese work and his profound description of the ritual associated with coming into the office, being physically examined. And we have to recognize this is a big change for many of these patients. Many haven't seen the benefits of technology in a virtual exam just yet. Patients may feel like you can't really see how profound the bruise on their arm is because their video feed is grainy. And I'm waiting for a new webcam that I ordered since mine's on its last leg, but I've seen some video feeds where I can practically see the pores on a person's face, which can impact that quality of the interaction, right? So many patients just feel like things will get missed. Many of the patients don't have the technology that would be helpful in collecting important data. They might have a scale or a thermometer, but things like a blood pressure cuff or the pulse oximeter, they're rare. Not everyone owns an Apple Watch. And I've been working on something called the Health Confessions Project for a few years with research on what people lie to their doctor about. And I won't go into details, but when I go into the doctor's office and I hop on a scale, I can't fudge the numbers. But we found that patients are shaving a few pounds when they report their weight during that virtual exam. So anyway, as we learn more about the telehealth experience and iron out the wrinkles, a tech upgrade for patients should be factored into the equation, where we can arm patients with that digital medicine cabinet that's reimbursed, as Dr. Sakamoto mentioned, to improve their experience and trust in that virtual physical exam. And then it's important for patients to realize that telemedicine is one modality in a spectrum of options they have to improve their health. Just because they have a few telemedicine visits doesn't mean they can't also have an in-person visit. Telemedicine can serve as a way to foster better connection and partnership with your doctor. It can be a way to engage people in their health. And I've often argued that the traditional office visit has always been somewhat flawed in that patients, they may receive a traumatizing diagnosis that knocks the wind out of them. And then they're given a ton of information around their options. And then they're potentially expected to make life-altering decisions in a very short time frame. So maybe telemedicine can help us reframe the decision-making process. So yeah, I think there's tremendous opportunity, but we have some work to do.
For sure, and I appreciate that. And I think you highlighted a couple of great points is really, and we'll talk about this a little bit in our next section on the telehealth literacy, but really understanding like when are you hitting up of the limits of either A, the technology, or B, the clinician's clinical skills across telemedicine, and how do you bolster those? That's actually, that segues perfectly into our next section. Actually, I'm double checking the Q&A here as well. Yes, questions about home visits and LPNs and navigation. We'll talk through that very shortly. And then the other question, can a provider add pictures and videos provided by the patients during documentation? And actually to Sarah's point about bruising and things like that, there are times where I'll actually have them as like, oh, I can't really assess that well over video. Can you take a picture and send that after we're done with the visit? So I think, like, again, knowing, again, when are you hitting up against the limits of technology? When should you switch to a slightly different modality? So I think all of these things, again, are kind of the art of telemedicine versus like the technology and the science of it. And we'll talk through that in our next section.
Perfect. Okay, so we've talked about how to make a human connection virtually, but aside from some of the things that we've discussed, it's important to also develop a foundation around telehealth literacy. And if you go to the next slide, I'll delve into the definition. Perfect. So most of you are probably already aware of the definition around health literacy, which is it's a person's ability to obtain, to process, to understand basic health information services, and then to make appropriate decisions around their health. And that definition has actually evolved over the years, where we're now probing into how people can use health information, not just understand it, so that they can make well-informed decisions. And it's shocking that only 12% of adults here in the US have proficient health literacy. Over a third of our population would have a challenge with common tasks like following directions on a drug label or following a child's immunization schedule. And we haven't cracked the health literacy nut despite the extensive guidance, although we've made a tremendous headway. And so now more than ever, to avoid exacerbating the digital divide, even though there are no formal telehealth literacy guidelines in place that I'm aware of, it's important that we think through telehealth literacy by not only ensuring that communications are provided at an appropriate health literacy level, but that we're also assessing the technical literacy of that patient. And technical literacy, by the way, might also need to be addressed on both the clinician and the patient side. We can go to the next slide, please. So again, I won't do a deep dive into health literacy, but I'll touch upon just a few basics. I think, again, most of us recognize the need to use plain language with few syllables, limiting our medical jargon. Even a simple word like negative can confuse a patient. Your test came back negative. To you and me, that's great. To a patient, negative means bad, right? Because they're taking it literally. So to ensure that a patient doesn't feel overwhelmed, it's also good to set an agenda for the visit, encourage them to ask questions. To avoid things like information overload, ideally you highlight 3 key points that are also reinforced. And then even though you might be communicating with that patient verbally, perhaps an after-visit summary that's written out is what that patient prefers. We all take in information differently, and in the ideal visit, the communication or the education that a patient receives, it's tailored based on how they prefer to learn and how they prefer to engage. So we actually developed a tool called the Learning Preference Barometer that assesses how people take in and act upon information, where we provide them with a summary of their learning preference, which they can then use to personalize the communications, and then they can also share that with their clinicians so that education communications can also be tailored based on that preferences. So aside from learning preferences, we all might have different tech preferences. I might search for health information online, but I might not be as tech savvy with my webcam, or frankly may not be as comfortable. So understanding preferences, helping with that learning curve, and then providing patients with different options based on the type of interface that can help patients realize the spectrum of convenient telehealth options. And then lastly, I can't emphasize this one enough, but preparation. Preparation before, during, and after the visit is key. And that's both on the patient side and the clinician side. And then arming that patient with guidance without making them feel like it's homework, that's important as well. And even when it comes to telehealth literacy assessment, it's important for the patient not to feel like they're taking a test. And I think that that's sometimes an issue when we're doing health literacy assessments. Patients take some of these questionnaires and it makes them feel like you're testing their intelligence. So we really have to think through how we're potentially assessing telehealth literacy over time. And Dr. Sakamoto, I know that telehealth competency has also been built into medical education. Can you touch upon some of those efforts?
For sure. Let me see if I can put my next slide up. Yeah, totally agree. I think it's being built into medical education. I think it's a work in progress. Is probably how I'd put it. But the same thing for the patient. I think feeling comfortable with the technology and getting care through telehealth. I think on the clinician side, kind of developing that confidence and competence to be able to do it. Just having that higher level of familiarity just helps you spend less time thinking about like, where's my camera? Is my video feed good? And actually spending more time with the patient. So I think it starts like most things, the earlier you start, the better. So really being able to, how do you incorporate telehealth teaching throughout the training years? So starting at medical school or whatever the initial training pathway is for that clinician, and then really continuing into the continuing medical education part. So I want to highlight the AMA just put out this telehealth clinical education playbook. I got a chance to read through it. It does a really good job of kind of setting the foundation of what are the baseline skills that that need to be in place. I think the other part that I think is important is having just kind of a standardized structure within a facility. So when you're onboarding your current clinicians, that in of itself, that's a large part of my role at Sutter, is kind of teaching old docs new tricks. So getting them to log onto an iPad, how to unlock your iPad, all of these things that you don't think about too much, and like my niece can do without thinking, is a skill set, and I think that an unrecognized thing that should actually be intentionally taught. So I think building on, again, both the technology piece, what is the familiarity with that, and then kind of seamlessly using the technology, providing patient care and going back and forth between the two requires practice and preparation, like Sarah was saying. So I think they're pick it up, you'll just get it, I think doesn't quite cut it. So having intentional teaching around this, and again, the AMA has done a great job about putting some of those principles together. So, but being very intentional about the teaching is a big part of the building telehealth literacy on the clinician end. And kind of thinking through, again, how do we build this? Running through some of that, I guess, Sarah, in your experience, because you've seen a lot of different health systems, what are some ways that health systems have kind of helped to build that telehealth literacy for their patient populations?
Yeah, so one is again going back to the point of providing patients with an overview of the spectrum of options available through telehealth, so that they can explore different modalities based on the health issue they're having. And I've seen bits and pieces of this done well, but patients need a deep dive navigation of the technology that's available so that they can better stock their digital medicine cabinet. I've also seen promotoras, community health workers, being used as a way to engage the Hispanic community, where the promotoras make house calls and they serve as the bridge, bringing with them the technology so that patients can connect virtually with doctors. And this can be reassuring for those who might have a fear that somehow their immigration status will be disclosed. So yeah, those are a couple of examples. I think that there needs to be more work again done to ensure that we're doing that tech assessment and aligning modalities with the preferences, but there's some headway being made, absolutely.
Nice. No, I appreciate that. I think, yeah, the goal is to get to like a little bit more proactive side, the preparation side. I don't think we're quite there yet, but for that in the moment, kind of at the elbow support, both for the patient as well as, to be honest, like some of the clinicians. I'm about to start a video visit. How do I get through these pieces? Having a person there, kind of, yeah, having that digital health navigator, digital technology navigator, again, for both patients and clinicians is super important. And again, we invite people in the chat as well to, if you've seen something either in your health system or have observed that a colleague's health system that has helped to bridge that gap. And again, because I think along with telehealth literacy really comes along with the digital divide as well.
Yeah, there's an interesting question in the chat about recording the visit, and we've actually recommended this to many patients, but some health systems actually don't allow it. So obviously you have to ask for permission to record the visit, and some clinicians haven't been as comfortable with that. But I think that that's definitely an opportunity to ensure that we're reinforcing what would happen, and then again what the patient potentially needs to follow up on.
Yeah, the other follow-on that I'll say for that is probably not recording the visit verbatim, because again, a lot of office of the legal side gets a little dicey about it, but the open notes movement is something I definitely recommend looking at. I think that's another way that patients can directly view their clinician's notes. And I think that's another way, again, for, I use it to remind myself what we did, but it's also a good way as a asynchronous way of communicating with patients. I think that's another piece to think about as we're going forward. It's a new way of practicing medicine. And again, the open notes movement has really kicked off in 2021.
Yeah, and although this might take a little bit more time, one of the effective practices that I've also seen is when a clinician co-constructs or designs, it's really co-construct the medical note during that visit, where the patient can actually see real time what the clinician is writing into that open note, even though they'll have access to it, but it allows, again, for that conversation to center around what's also being documented.
Yeah, and actually the next question goes off that pretty well as well. Is they're an avenue in which the patient can send the provider questions they have prior to the visit, so the provider could be well prepared. I do that all the time. So I think actually a lot of my telehealth visits tend to be shorter because there's a lot of back and forth asynchronous. So like basically through my chart messaging with the patient to prep for these things. So I think getting in the habit of that, having for me, it allows my visits to the synchronous parts of the video visits to be a lot more high yield because the patients are getting their easy questions kind of answered up front. There's not a lot of information extraction happening during the video visit. It's mostly about counseling, and being able to skip that part just makes, again, for me, the visits a lot better, and I hope it is for the patient as well.
Yeah, we've actually, this is both in person and the virtual visit. We've typically armed patients with different questions to ask along different points of their journey. And then we ask them to highlight which questions they may want to ask in that next visit. But we recommend that they share those questions in advance because, again, it can also set that agenda, if you will, and ensure that there's enough time allocated for that discussion.
What are the digital empathy techniques that you can have and physical exam techniques that are happening in the video visit itself? But that, as you can see with this graphic, one small part of what I call virtual care, not just telehealth. So a lot of the asynchronous texting, chat bots, store and forward are kind of when you take a picture of a rash and send it ahead of time or afterwards. So what are all the different ways that, again, to my earlier point, the video visit shouldn't replace the in-person exam. I think there's a place for that. I still have a physical clinic in San Francisco that I see patients in, but how can you use virtual care to really augment that wraparound care, that continuous care that we're able to provide patients? Sarah, I don't know, what other kind of thoughts that you have around just the possibility?
And I mentioned the need to talk about the spectrum of options, but it's also important for this to be scenario-based so that they have context. So for instance, I may surf the internet. Do we even say surf the internet anymore? But okay, I may surf the internet for health information online. I might look at lab results on my patient portal. I might message my doctor to get a prescription refill, but it doesn't necessarily mean I want that virtual exam, and that's okay, right? It'll take time for patients to get comfortable with different options, and we all have different preferences. So it's important for us to personalize touch points based on a person's preferences and comfort levels to enhance that engagement over time. But really, again, talk through some of the potential scenarios where they might interface with some of these modalities as well.
Yeah, and I think to me, this goes back to the telehealth literacy part of navigation is like, one, understanding what are even the options, Sarah, to your point. And then two, as the clinician and or clinician staff and or patient, how do you navigate all these different options as well and help choose through that? So that's all part of that telehealth literacy and building up that skill set and knowing what things are available. Let's see. And the last point that we wanted to talk through was, again, I use, we're doing this on an AMA webinar, but they've come out with very good frameworks that I love using. So I think looking at what's the return on health, particularly for telehealth, there's these different value streams, particularly pertinent to the stuff that we're talking about today, I think is looking at what does the patient and family experience look like and the clinician experience look like while on telehealth. And an open discussion kind of for the group and for the AMA to take on is what are some like novel or modified metrics to capture the patient and clinician telehealth experience? What are different ways? Because it's different. It's different than in the in-person experience. And how does this get reflected in Prescania or HEDIS or other things that we're doing? But recognizing that this is becoming a larger proportion of the way we provide care, how do we account for that? And then, with any metrics, how do you find targeted, actionable feedback to improve future visits? Both patients telling their clinicians, but maybe also clinicians feeding back to the patients. Sarah, any other things?
Yeah, and I love the idea of the bidirectional feedback where both patient and clinician can provide that real-time feedback on the experience, right? So how well prepared was the clinician for the visit? How well prepared was the patient? What would they like to see in the future? And these metrics shouldn't be tied, the metrics should be tied to learning from one another, right? Versus reimbursement or placing blame. It shouldn't feel like we're grading one another. It's more about continuous improvement of the overall experience.
Yeah, I like that. Yeah, more than just the 5-star rating right now. I think having the dialogue and being able to find that balance is super important.
I would also include a metric tied to the experience outside of the actual virtual exam. Front office staff, how easy was it to make an appointment? Logistics. I think that all factors into the overall experience and should be tied into that metric as well.
I totally agree. So yeah, thank you everybody. I always have fun doing these presentations, and Sarah, thanks so much for coming along for the ride. Curious to know about the role of clinical decision support systems for telehealth visits. I think that's in the works. It's kind of this idea of like smart routing, or like based on a patient's clinical concern, where do they go, and clinical concern and preference, where do they go? So I think that's in the works. A couple of, again, it goes to that digital front door, digital health navigator that I've seen some of that do some of that routing. Sarah, I'm not sure if you've seen particularly helpful or particularly good examples of getting patients at the right place at the right time.
Yeah, so decision aids as a whole, I've seen some done really well, but then when they're integrated into the exam, they don't work as well. And so really thinking through how decision support can also be done potentially before and after the virtual visit might be interesting to further explore as well. And I love the comment here about keyboards. They bought they bought reduced sound keyboards so patients don't hear the keyboard when needed. And that was actually an issue that patients cited, where they felt like the doctor wasn't listening to them because they were hearing the clicking of the keyboards. I didn't know that they had soundless keyboards. That's something to invest in for sure.
Yeah, and I'll say, even just personally, I've moved mostly when I do patient visits, I tend to use in-ear headphones and not just like whatever the laptop microphone is specifically for that reason. James had a question: is there a role for the nurse to be present with the physician during a telemedicine visit? Oh, we can chat offline about this too. There's a whole thing about kind of advanced primary care and advanced team-based care. Jeff Panzer did a article. He's a Chicago-based family medicine doc. But there are ways to, I've seen a couple of places that have really supercharged it with this. I'd say most, to be honest, the downside of a lot of the telemedicine stuff is I do a lot myself these days. So I'd say more places have kind of the clinician taking on a lot of the roles, even like check-in and MedRec, but the opportunity for advanced team-based care in a virtual setting is huge. But I haven't seen a lot of places really grab onto that yet. Sarah, I don't know about you.
Yeah, we've also actually seen nurses schedule visits after that virtual physical exam directly with the patient to answer any additional questions, to reinforce education, follow up, things of that sort, and potentially address any challenges that they might be having and paying for the medication. That we've also seen it happen after that physical exam as well.
Yeah, and actually, I think Stephen had a point about, we found it very useful in family medicine to have a virtual scribe listen in by audio. Again, that's kind of how do you virtualize parts of the visit, have other people participate virtually. That's a great example of doing that. Another question: how much longer has physical exam taken due to explaining to patient how to do? In other words, length of telehealth visit compared to in-person. So from that standpoint, I think because the visit tends to be more targeted, almost uniformly, most follow-up visits that I do by telemedicine tend to be shorter than what I do in person. So it might take you a little bit longer to walk the patient through a shoulder exam, but you're not spending time listening to the heart, listening to the lungs, feeling the belly, that we kind of just do anyway because the patient's in front of us. So it's a more targeted exam. So I'd say it probably takes about the same time to most times faster.
Yeah, and I love the question here about looking at the camera versus the screen. And I often have a problem with this as well, where I try to look at the camera, but you're often looking at the screen and you're typing into it. It requires a balancing act. And Dr. Sakamoto, really interested in your thoughts there, how to ensure that you're paying attention, taking in gestures the patients might be making, reactions, while simultaneously, again, making that eye contact.
Yeah, it's practice, because I think before you're triangulating the EHR and the patient, and now you're kind of triangulating the EHR, the webcam, the patient's camera, the patient's video. So really being able to bounce between those three things, it was hard at first. I think it's gotten better with time, but it takes practice. It's just holding multiple things in your head at one time. Paul had a question about, how do you structure the balance of virtual visits while at the office? Block time in the day for urgent virtual, do all day in office, then all virtual. I'm a big proponent of blocked time. The mindset that I bring to a virtual visit, just like the mechanics of a virtual visit versus like rooming a patient and kind of those different time lags in person, are so different that I have a blocked day for telehealth like on Mondays, and then in-person clinic days tend to be on Thursdays. trying to I'll say most places I've seen that have tried to do that interspersing, it just doesn't work out quite as well. So I highly recommend at least blocking by half days.
I guess question for you both, for myself, I think I think there's opportunities, and you shared a list of some of the different digital tools that, can optimize that patient experience. Can you just talk a little bit more about, how do you make sure that the patient, is comfortable using that and maximize the virtual visit? Is that an opportunity where you can leverage staff members, kind of reach out in advance or assess it asynchronously through messaging?
Sorry, I'll let you take first crack.
Yeah, so I think the use of tech navigators. So we have navigators in healthcare in general, but specifically tech navigators that can help that patient in advance get comfortable with the technology. That's imperative. I've seen some health systems that are starting to do that. I think that there needs to be more adoption to ensure that, again, patients aren't stressed about, are they working the blood pressure cuff correctly? But doing that in advance of that visit, I think is tremendous.
Yeah, a lot of health systems will offer kind of like that practice visit one, just purely like, does your connection work? Does your iPhone version match whatever the video software is? So I think like and I don't see a lot of patients take advantage of that, and or a lot of health systems really push that. But I think having that one practice session, again, for just technical comfort and then getting used to it, so that when you're doing the actual visit, a lot of those first time jitters are out of the way can really make a big difference.
Yeah, and it's interesting. One of the things that we're putting a spotlight on is the digital medicine cabinet, where we also, there's different types of tools that can be deployed during that virtual visit. Some work better than others. So for instance, we just learned about the soundless keyboard, that's on the clinician side, but there might be other tools that the patient can also utilize. So we're actually working on collecting reviews around different tools. How comfortable were they using that tool? Any issues that they might have, so that if they're looking for, the perfect thermometer, there's a ton of options, but they're potentially looking at those reviews as well as part of that digital medicine cabinet.
And one thing I'm just realizing as we're coming up on time, so both of our email addresses are up here too. I think a couple of questions we haven't really gotten a chance to get to, but as I said, feel free to email me. I love chatting, meeting new people, and these forums are great for that as well. I guess, Bernadette, are there any questions you've kind of been monitoring both? Any last few that you want to highlight or bring out for both of us?
One that, I think just like stuck out to me too, just, talking at warp speed, right? Isn't that a tendency, right? That is just like, I don't know, there's something about the virtual experience that makes you feel like you need to talk faster. I don't know if you have any tips for that.
It's being intentional. I talk fast, even in person. So it's not just the telehealth part of it. Patients have also asked me, do you usually talk this quickly? Answer is yeah. So I think it's making sure, and again, but the thing I do appreciate is patients will also call it out. And I think it's helpful to be like, oh, can you slow down? I can't hear you. So I think it's practice and listening to the patient as well. And a lot of my patients aren't afraid to tell me to slow down.
I'm smiling because I also have an issue with talking super fast. That's the New Yorker coming out at me. But I actually have a post on my computer that says slow down. It's practice. Practice makes perfect. But I do feel like virtually we tend to talk a little faster.
Awesome. All right. Well, thank you both so much. And as mentioned, their contact information is here on the screen if you have any additional questions. And if we could go to the next slide. I just wanted to make mention of our next Telehealth Immersion program event. We'll be co-hosted together with ACAI, and we'll focus on the use of telehealth for allergy, asthma, and immunology. Featured speakers will include Dr. Tanya Elliott, Chief Medical Officer of Virtual Care at Ascension and Chair of the Telemedicine and Technology Task Force at ACAI. And she'll be joined by Dr. Sophia Velartas, Assistant Professor of Medicine and Associate Program Director of the Allergy and Immunology Fellowship at UNC Medical Center, Chapel Hill. So should be a great event. You can register for this session on our website. And again, it'll take place on February 18th at 11 a.m. Eastern. And just to wrap up our session here today, we kindly ask you to just take 1 minute. There's going to be a 4-question survey. We'd love to hear your feedback. And as always, I think on the next slide is our contact information here at the AMA. If you have any questions or suggestions for additional programming, please feel free to contact us and let us know. We'd love to hear from you. So thank you again, Dr. Sakamoto and Sarah Krug. We really appreciate it. This is all incredibly helpful information. Everyone, thank you so much for joining us. Have a great day.